Hello dear colleagues, it's a pleasure to present you my presentation about high-density mapping of intra-atrial re-entrant tachycardia in adults with congenital heart disease. And so why do we need multi-electrode and high-density mapping? Well, as you can see in this work by Ante and colleagues, in this upper panels, what you can get is a voltage map if you do the mapping with a linear ablation catheter, so 3.5 millimeter tip, and you can appreciate that you have here some low voltage areas. But if you map the same atrium with a multi-electrode, small electrode, high density mapping catheter, you can appreciate that the voltage is much better because more of the voltage is detective. And we compare then the voltage in these two groups. And what you can see is that multi-electrode mapping provides more insight into the true anatomy and the true voltage of these patients, and conclusive mapping is possible even in very scarred and low voltage left atria, like in this right panel where you can see there is some scarring already previously existing. So why is this important in ACHD patients? Well, we expect here diseased and low voltage tissue, for one reason because of surgical interventions, like here in a mustard patient, so where you have anatomical scars and atriotomies, but we can expect also functional or hemodynamically induced low voltage by volume overload of atria, by excessive pressure and valvular insufficiency. And this stretch leads then to remodeling and fibrosis and reduced conduction velocity, like for example in this patient with an Epstein anomaly with this huge atrialized RV, where this right atrium will for sure have not normal signals. Now, what can we say about high density mapping of so-called simple macroentries? Well, this is an interesting work from the Bordeaux group where they mapped 42 perimitral flutter, and you can see here an example of such a perimitral flutter in the 3D reconstruction and the high density mapping. Here's the mitral annulus, and you can appreciate here the reentry around the mitral annulus. And they found that of these 42 perimitral flutters, some, 38%, fulfilled this prejudice that the circuit comprises the entire mitral annulus, but not more. Whereas they had also cases in 14% where the circuit is longer than the total entire mitral annulus, but the complete mitral annulus is included in the circuit. Whereas they had even half of the patients where the circuit was longer than the entire mitral annulus, but did not comprise the complete mitral annulus. As you can appreciate here, this part of the mitral annulus is not part of the reentry, but the conduction is turning around here and then sparing some part of the mitral annulus, and it would be useless to, for example, develop a line where you ablate here on that part of the mitral annulus, which is not part of this so-called perimitral flutter. So high density mapping provides us the possibility to develop an individualized ablation strategy, start targeting the low or no voltage isthmus. This is an example of a patient who was operated with a mitral valve repair. You can appreciate that we look here from the right lateral view on this left atrium, right superior pulmonary vein, right inferior pulmonary vein, and we have here the HD grid catheter, which is such a high density multipolar mapping catheter, probably on the scar where the surgeons entered this left atrium. You can appreciate that here the signals are very, very fractionated, but also very low voltage. And we could delineate that the whole reentry, in fact, was located here in the septal posterior septum of this patient. And if you look at the same location with the ablation catheter, you can appreciate that there is no signal on the ablation catheter, which is placed here in these white lines, nothing to see, whereas we could see very nice signals with our high-density multipolar catheter. But it's the right spot. So if we ablate here, you can appreciate here that after a few seconds of ablation, the atrial tachycardia stops, which is, of course, what we wanted to do. So no signals in the ablation catheter, but still it's the right spot, and we could have not detected this with the ablation catheter. So what are the results of this high-density mapping guided ablation? So this is a group of 250 patients. They had previously undergone atrial fibrillation ablation and had now atrial tachycardia. And you can see that these patients have been all ablated on. The number of previous ablations was 2.2, and the group then did really a high-density mapping of the left and right atrium. You are reading right here, 15,000 points in mean acquired in the left atrium and 7,500 in the right. So really a very high density mapping to understand the mechanism of the atrial tachycardia. And you can appreciate here the single procedure outcome. So if the patients came with an atrial tachycardia, we could, with this one procedure, achieve sinus rhythm about 55% of the patient, which doesn't sound like a lot, but if you look more detailed into the data, only 2% of the patient had the targeted atrial tachycardia recurring. So most of these recurrent atrial tachycardia were new onset different atrial tachycardia. And if we look at the multi-procedure outcome, where then these new onset atrial tachycardias were targeted as well in the next procedure, you can see that the results are really satisfying. So what about an ACHD patient? Well, in ACHD patient, this fact that there might be some low voltage areas is even more pronounced than in normal patients. And you see here the work of a mixed group of 81 patients with previous congenital heart disease. You can see here the conditions that they were suffering from, so a very mixed cohort of patients. And you can see that the authors were able to differentiate between macro reentry, atrial tachycardia, and localized reentry. And they could differentiate, first of all, by the mapping, of course, but also because they could map how low is the voltage in the isthmus that will facilitate this reentry. You can see here, this is a perimitral macro reentry, that in this isthmus here, the conduction velocity is quite reduced with 0.17 meters per second. But in this localized reentry, just adjacent to the ostium of the right superior pulmonary vein, the conduction velocity is even very much smaller, 0.04 meters per second. So very slow conduction zone that enables this reentry to circulate here on a very small space. It's a localized reentry, if you want, so on the roof of the left atrium. And it's very important, of course, to detect this zone of very extremely slow conduction, because you have to ablate this zone to eliminate this reentry, but also to eliminate the next reentry, which would be possible, for example, around the right pulmonary veins, just because this extremely slow conduction zone is here. So we have to detect these very slow and low voltage areas to then successfully ablate arrhythmias. And I want to present you two cases from our hospital. This is the first one. It's a 28-year-old male with Holt-Oram syndrome, surgical repair of the VSD, had a tricuspid valve repair, and then 2015, a valve-in-valve in this tricuspid region with also a mitral valve repair at the same occasion. We ablated him already once for typical atrial flutter, and now he had a recurrent reentrant tachycardia, a cycle length of 300. You can appreciate that the CS catheter placement was quite difficult, looking at the position of the CS catheter. If you will look now at the high density mapping of this right atrium, and you can see here two views. One is so right lateral to right posterior a little bit, and here more or less classical LAO view. You look here at the voltage mapping, which was performed with the HD grid catheter with the omnipolar technology, which provides an even higher resolution of the electrograms. And the lower limit here of the voltage is set to 0.05 millivolts, so almost nothing. And you can appreciate that in this region, where we suppose that the atriotomy probably took place, we have very low voltage signals. Even on that HD grid, even with the omnipolar technology, we can barely distinguish some signals here. On the other hand, we did really a high density map of that right atrium, as you can appreciate here, over 2,800 points that were used for this map. So if you look now at the LAT mapping of this patient, and now the colors stand for activation timing, you see here is an early spot, then red means still early, and then this activation front circles around. Here is purple, so the latest. And then the system has problems to assess the timing here, and that's exactly the region where I could show you the electrograms before, almost barely visible small low voltage signals. And if you look at these vectors, which now will sort of delineate the activation front, you can appreciate that the vectors are going around and they're almost disappearing here. So even this very high density mapping catheter has problems to detect these very slow signals here, but that's the critical isthmus. That will be the isthmus where you have to ablate this re-entry, this atypical right atrial flutter localized re-entry. And that's again the voltage mapping, and you can appreciate how low the voltage is here in the region that forms the isthmus, the critical isthmus for this tachycardia. Again, with the vectors overlaid, you can appreciate that the activation front is running through here, and you can also appreciate how much delayed and slowed down the conduction here is. Almost not visible how the vectors cross this. That was then the ablation strategy. We ablated these very low voltage areas, and to tell you the truth, we started here, and at the second point we were already done. The tachycardia stopped already. We continued to do this line and to really close, eliminate the low voltage area. Second example, surgical repair of Tetralogy of Fallot, ACHD occluder in 2008, and you can appreciate here the transeptal puncture just cranially to this ACHD occluder. We ablated that lady already several times. She had typical flutter, had an atrial tachycardia around the atriotomy, recurrent periatriotomy, AT, so a line to the IVC redrawn, and then a right atrial re-entry involving the posterior right atrium. And finally, in this procedure, we went also to the left atrium, did a pulmonary vein isolation and a roof line. And in the last procedure, she had already a scar-related right atrial re-entry that was located more or less on the septum of the right atrium, pulmonary vein isolation, roof line. So you see that difficult case. This is when we managed to place the wire into this left atrium, just cranially to the occluder. And that is now the left atrial voltage mapping, again with this very high resolution. And what you can see is there is a line of block probably here on the roof line, which we draw twice. The pulmonary veins look isolated, and here is some very large scarring area on the anteroseptum of this lady here, if you look from the right lateral view. We did, of course, then an LAT map of this left atrium, and you can appreciate again by the colors which timing the activation took place. And what you can appreciate as well is that if you look at the activation, there seems to be a line of block here, and the activation cannot cross, as you can appreciate here. So if we look at the sparkle map that is superimposed on the voltage map, and you can watch that several times, you can see how the activation front seems to emerge from here, that's the right atrium, and then runs along the anterior wall from septal to lateral, but it runs also along the posterior wall from septal to lateral. So I think we can be sure that it's not perimitral, because we have two wavefronts colliding here in the lateral array, one coming from anterior, the other one from posterior. So there seems to be the problem here in this region where this activation front seems to emerge from, and as you can appreciate again here, it really seems to emerge from this. Area. And that's then what we found out with the right atrial mapping, which is unfortunately shown here. This was a septal localized reentry just beneath the right superior pulmonary vein, and we finally ablated it from the right side. So this is the HD grid placed on the right atrial septum, and we could ablate this right this septal reentry here from the right and the left side. You can appreciate we ablated also from left side, right side, and then could eliminate. So in conclusion, high density mapping means that we have a multi-electrogram mapping. We have more, and which is even more important, more detailed information about this whole atria. The high resolution mapping provided is provided by these small electrodes and the narrow spacing. You can map even extremely low voltage. And this is probably the most important point, you can detect extremely slow conducting isthmuses with conduction velocities that are way below any kind of normal conduction velocity that you can observe in the rest of the atria. But you have to target these slow conduction zone. You have to delineate the activation course, but you have to target these very slow conduction zone to eliminate the isthmus of these atrial tachycardias, and to prevent also then the next reentry that might be dependent again from the same extremely slow conduction zone. So in conjunction with dedicated 3D mapping system, this high density mapping really provides a very powerful tool for the elimination of all these atrial tachycardias. Thank you for your attention.